Thank you for your presentation and introduction. My task today is to discuss the role of octreotide in preventing pancreatic fistula in soft pancreas. As it was already stated, improvements in both operative techniques and perioperative management of patients undergoing pancreatic duodenectomy have decreased the operative mortality rates less than 5%. However, postoperative morbidity remains high, from 30 to 50%, and pancreatic anastomotic failure can be one of the more serious and vexing complications. A clinically relevant pancreatic fistula type B and C results in postoperative morbidity requiring invasive intervention, prolonged hospital stay, and increased cost and occasional readmission. The best strategy to prevent pancreatic anastomotic failure remains a clinically relevant goal. What are the risk factors associated with pancreatic anastomotic failure? It has been identified: patient characteristics, deleterious impact of high body mass index, increased thickness of visceral fat and abdominal wall fat, operative factors, greater operative time, greater blood loss, use pancreatic gastrostomy compared with pancreatic duodenostomy, and pancreatic glandular factors such as soft pancreatic texture, small pancreatic duct less than 3 millimeters, absence of parenchymal fibrosis, fat infiltration of the pancreatic parenchyma. Risk factors may be selected on the basis of pancreatic gastrostomy versus pancreatic duodenostomy, end-to-side versus end-to-end, ductal mucosa versus invagination, the use of a stent or no use in the stent. But the question remains how to prevent pancreatic anastomotic failure and the use of somatostatin. It should be recommended. Somatostatin and its analogs are known to have an inhibitory effect on the exocrine secretion of the pancreas. These drugs have been presumed to reduce the rate of pancreatic fistula. In previous studies, several randomized studies have suggested a statistically significant decrease in overall postoperative complications after pancreatic duodenectomy with the use of perioperative octreotide. However, other studies reported no statistical benefit for the perioperative use of octreotide. Results of meta-analysis are also conflicting. Therefore, the evidence of octreotide use is still lacking to give a clear recommendations or guidelines. The aim of our study was to evaluate the effect of octreotide on pancreatic remnant exocrine function after pancreatoduodenectomy and to assess the efficacy of this drug in the prevention of pancreas-specific complications in patients undergoing pancreatoduodenectomy for pancreatic of periampulary lesions, excluding chronic pancreatitis. The patients were enrolled in this study. In one group, we used octreotide, in another group, placebo. The randomization process was carried out during the operation. Octreotide group, they used 100 micrograms during operation and every 8 hours after surgery for 10 days. And in the placebo group, 31 perioperative doses of saline. The statistical analysis, it was calculated that 24 patients were required in each group. To ensure adequate analysis, trial aimed to recruit a minimum of 30 patients to each treatment group. In the consort diagram, 62 patients were eligible for the use of octreotide or placebo. In all patients, they were operated on using the technique of pancreatogastrostomy with invagination anastomosis and an external drainage of the pancreatic duct with the elastic tube we use in all patients. Amylase levels in serum and drainage fluid measured on days 1, 3, and 5 after surgery, and daily pancreatic juice output measured for 10 days. Lipase output in pancreatic juice was measured for 10 days. Pancreatic fistula graded as B or C according to the International Study Group Pancreatic Fistula Grading System was analyzed. The assessment of pancreatic characteristic, pancreatic duct diameter, grade 1 less than 3 millimeters, grade 2 between 3 and 5, and grade 3 greater than 5 millimeters, and pancreatic consistency was subjective criteria and based on visual and tactile information, and there were one group with hard and another soft pancreas. The study endpoints. The primary endpoint was the evaluation of the effect of perioperative octreotide given at the time of operation on remnant exocrine secretion and pancreatic stump-related complications in patients undergoing pancreatodonectomy for pancreatic and periampulary lesions, and the secondary endpoints: overall morbidity, hospital mortality, and duration of hospital stay. What about the results? The 32 patients were included in the octreotide group and the 30 patients in the placebo. In each group, half the patients had pancreatic adenocarcinoma. When we categorize diameter of the main pancreatic duct and pancreatic consistency, as we can see on the slide, patients with the Pearson duct less than 3 millimeters, less than 5 millimeters, associated more frequently soft pancreas. However, when the Pearson duct was greater than 5 millimeters, the association was more frequently with hard pancreas. When we categorize diameter of the main pancreatic duct and pancreatic consistency, in the group of patients with pancreatic adenocarcinoma, hard pancreas was more frequently associated with Pearson duct with a diameter between 3 and 5 millimeters. However, soft pancreas was more frequently associated with a Pearson duct less than 5 millimeters. When we categorize the main pancreatic duct and pancreatic consistency with a diagnosis, the group of patients with periampulary tumor associated more frequently soft pancreas, and when the patients, when they have adenocarcinoma of the patient, of the adenocarcinoma, they associated more frequently hard pancreas and Pearson duct greater than 5 millimeters. Then, when we come to the medial total pancreatic juice output during 10 days, no difference whatsoever between the group of patients with octreotide and with placebo, and we stratified the patients depending on the diagnosis. The octreotide, the patients with pancreatic adenocarcinoma associated median total pancreatic juice output significantly less than the group of patients with periampulary tumor, but no difference whatsoever between the octreotide and placebo group in the diagnosis of pancreatic adenocarcinoma or whether patients had periampulary tumors. When we categorize daily pancreatic output during 10 days, the group of patients with periampulary tumor daily associated with a greater amount of pancreatic outjuice comparing with the group of patients with adenocarcinoma, and no difference within these 10-day periods between the octreotide and placebo groups. When we categorize diameter of the main pancreatic duct and median pancreatic juice output, the median pancreatic juice output was greater when the pancreas had a Pearson duct greater, less than 5 millimeters. However, the median pancreatic juice output was less when the Pearson duct was greater than 5 millimeters, a statistically significant difference. When we measure lipase content in the pancreatic juice, there was a difference between the group of periampulary tumors compared with adenocarcinoma, but the lipase content was no different at day 3 and 8 between the groups placebo and octreotide. Regarding the postoperative outcomes, no difference in the pancreatic fistula rate between the octreotide and placebo group, and other complications as delayed gastric emptying, interabdominal abscess, and surgical site infection, no difference between octreotide and placebo group, and no difference in the hospital stay between the two groups. Then, in conclusion, Mr. Chairman, adenocarcinoma associated more frequently hard pancreas in virus duct greater or equal to 5 millimeters. Periampillary tumors associated more frequently soft pancreas in virus duct equal or less than 3 millimeters. The total pancreatic juice output was not significantly different between the octreotide and the placebo groups. Significant lower outputs were recorded in patients with hard pancreas and dilated pancreatic duct compared with soft pancreas and Wilson duct equal or less than 3 millimeters. Morbidity and pancreatic fistula rate were not significantly different between octreotide and placebo groups. Then, in our discussion, this study did not demonstrate an inhibitory effect of octreotide on the exocrine pancreatic secretion and suggests that the routine use of octreotide cannot be recommended. Thank you for your attention.